For thousands of years, surgeons expected wounds to ooze. They even called it laudable pus, believing suppuration was a natural, necessary part of healing. Today, we operate with a completely different mindset. The mass production of penicillin in the 20th century created a powerful chemical illusion. We began to assume that whenever an infection occurs, a pill or an IV drip alone will solve the problem. Imagine a patient recovering from a complex abdominal surgery. They develop a deep surgical site infection. The medical team immediately pumps them full of powerful broad-spectrum intravenous antibiotics. But instead of recovering, the patient rapidly deteriorates. This clinical dashboard shows 4 critical metrics signaling a systemic crisis: a heart rate climbing over 90, a respiratory rate above 20, an extreme white cell count, and an abnormal core temperature. This is the medical threshold for systemic inflammatory response syndrome, or SIRS. Because this specific systemic response is driven by a documented infection, it crosses the line into sepsis. Left unchecked, that severe inflammation triggers a cascading failure known as multiple organ dysfunction syndrome. The most advanced chemical interventions in modern medicine are actively running through this patient's veins, yet the bacteria survive. The drugs fail because they are being deployed against an entirely physical state of infection. To understand why the drugs fail, we have to trace the bacteria to their source. People often blame a dirty hospital environment, but most post-operative infections are endogenous. The organisms already live inside or on the skin of the patient. A surgical incision provides a direct pathway. Normal, otherwise peaceful biological flora from the bowel or the skin use the cut to bypass local host defenses and dive straight into deep, vulnerable tissue. Whether those bacteria take root depends heavily on the host. If a patient has poor perfusion, meaning inadequate blood flow, or suffers from metabolic diseases like diabetes or severe malnutrition, their immune system lacks the capacity to contain the bacterial load. Surgical variables multiply that threat, leaving empty dead space behind the incision, failing to clear trapped blood known as a hematoma, or leaving behind foreign materials like thick sutures, physically lowers the tissue's resistance to those invading bugs. This cross-section compares the clinical spectrum. A minor surface infection might cause slight discomfort and resolve with minimal care, but a deep organ space infection aggressively invades the deeper musculofascial layers, demanding an intense biological response. When host immunity is compromised and surgical variables amplify the bacterial load, the body reaches a breaking point. It reacts by walling off the invaders, isolating the threat into a completely new, highly dangerous biological structure. This new localized structure is an abscess. On the surface, it presents with intense heat, severe redness, visible swelling, and a complete loss of local tissue function. This diagram shows the internal physics of an abscess. The core is packed with hyperosmolar, purulent material. This dense, toxic fluid acts exactly like a magnet, constantly drawing surrounding water inward. As fluid continues to rush in, the internal pressure spikes. The cavity pushes violently outward, severely stretching the surrounding healthy tissue and generating the extreme, localized pain characteristic of the condition. And here is the fatal flaw in relying on medicine. That extreme internal pressure collapses the surrounding blood vessels. This physically blocks IV antibiotics from ever reaching the bacteria. The drugs bounce right off the impenetrable outer wall. Chemistry cannot penetrate physics. The absolute rule of surgical infection is source control. The pus must be physically drained. Antibiotics cannot dissolve dead tissue, and they cannot bypass crushed blood vessels. An enclosed infection is a structural problem that demands a strictly structural solution. Antibiotics do have a crucial role in surgery, but they belong at the beginning of the timeline, deployed as an early preventative strike rather than a late-stage rescue. Look at this timeline starting from the moment of surgical incision. There is a critical window of roughly 4 hours following tissue contamination, the decisive period, where pharmacological prevention actually works. To win the battle, the drugs must saturate the tissues before the bacteria arrive. Surgeons administer them intravenously, right at the time of anesthetic induction, securing the site well before the decisive period closes. Beyond the IV drip, prevention relies on a strict physical protection bundle, meticulous hand hygiene, rigorous theater discipline, eliminating dead space inside the wound, and keeping core temperature stable. If an operation involves heavy contamination from the start, surgeons utilize delayed primary closure. Instead of trapping bacteria inside a closed cavity, they deliberately leave the wound open to heal from the bottom up by secondary intention. And if a patient's condition deteriorates after 48 to 72 hours of empirical therapy, clinical rules dictate a physical reassessment. The team must actively hunt for undrained pus, rather than blindly swapping antibiotic classes. True surgical mastery relies on the strict mechanical protection of the wound and swift physical drainage when defenses fail. Chemical interventions are a tool, but source control is the cure.